In August 2009, Mindy, a 25-year-old struggling new parent, experienced what doctors later concluded was a psychotic episode. She had been staying in a cousin's spare basement room in DeSoto, Kansas, while trying to get on her feet after an unexpected pregnancy and an abusive relationship. She'd been depressed since her daughter was born and was becoming increasingly distrustful of her relatives. Isolated, broken, and scared, one Saturday morning, she cracked. She woke to change her 5-month-old daughter's diaper. When Mindy looked down, she believed the baby's genitals had been torn. Mindy's mind raced for an explanation. The one she came to, that her baby had been raped the night before, that someone, she did not know who, had put sedatives in the air vents. Mindy called her pediatrician's office. A receptionist told her to take her daughter to a children's hospital in nearby Kansas City, Missouri. Doctors there found no evidence that the girl had been harmed or that any of what Mindy claimed had actually happened. After Mindy started arguing, medical staff sent her for a psychological evaluation and notified local child welfare authorities, according to court reports. That night, authorities took emergency custody of Mindy's daughter, Q. A court-appointed doctor later concluded that Mindy had experienced postpartum psychosis. But Mindy rebounded after that episode. She began to attend therapy and to see a psychiatrist who prescribed an antidepressant. She found a job as a shift manager at Kmart and moved into her own apartment. Each morning, she'd call the foster home where her daughter had been placed and she'd read Q a book. In time, her psychiatrist, therapist, and even a panel of judges concluded that Mindy should get her daughter back. I found the help I needed to be healthy, says Mindy. I was dealing with some mental battles at the time. Dr. Stanley Golan, the psychiatrist who treated Mindy, diagnosed her with a mix of post-traumatic stress disorder, likely, a therapist later said, related to abuse, depression, and possibly a kind of mild delusional disorder. Still, the diagnoses, Golan said in court testimony, do not interfere with her parenting, and she is able to adequately care for Q. You can have these diagnoses and be symptom-free, he testified. Indeed, in September 2011, Mindy, who was in another relationship, gave birth again to a boy named Jace, whom she's now raising capably on her own. Citing Mindy's pending case over Q, Kansas authorities took Jace at birth and placed him in foster care, but they soon returned him after finding no evidence that Mindy posed any risk to her son. As a family therapist testified, Mindy had provided a nurturing, loving environment and had met all of Jace's needs. Yet 4 years later, after a protracted series of court fights, Mindy does not have her daughter back. I couldn't see how they could keep one while I had the other, said Mindy, sitting on the carpet in a living room with her son, surrounded by toy trains and a pile of books. I don't think I should have to fight for my own child to come home. Missouri and county child welfare officials declined to discuss the case. The question in Mindy's case is not about what authorities did when she plunged into a mental health crisis. Nearly everyone involved in the case, including Mindy's own attorneys, agrees it was likely appropriate to remove her baby that day. Instead, the issue is whether a mental health diagnosis itself, in the absence of any harm, should be enough to keep Mindy from ever getting her daughter back. Mindy received treatment for her mental illness. She was diagnosed with depression, anxiety, and a mild delusional disorder, and has since rebounded. Under a concept sometimes called predictive neglect, Missouri and about 30 other states allow courts to terminate a parent's connections to a child if authorities conclude a mother or father has a mental illness that renders them incapable of safely raising the child. Officials usually must present evidence that the illness poses a threat. Most cases involve significant mental illness, not run-of-the-mill depression or anxiety. Yet there need be no evidence of actual harm or neglect, just a conclusion that there is a risk of it. States typically do not track how many parental termination cases are related to mental illness, or how often parents have lost children based on a diagnosis. New York, one of the few states that does tally such cases, has about 200 parental terminations annually based on mental disability, a category that includes both mental illness and quote-unquote mental retardation. If there were a similar rate nationally, that would amount to several thousand cases per year. The cases are typically sealed, and there's no way to know how many involve court overreach. But if it's impossible to know how many parents lose children unnecessarily because of the stigma of mental illness, it's clear that the process for deciding such cases is deeply flawed. Courts' decisions rest on the recommendations of evaluators, who often do not observe parents at home or examine their actual record of parenting. Instead, they rely on psychological tests and case notes. Incomplete evaluations are an endemic problem, said Joanne Nicholson, who directed a unit that conducted parenting assessments for Massachusetts child welfare agencies and is one of the country's leading researchers on parents with mental illness. Parents are often evaluated without a real analysis of their supports, of the life they actually lead, said Nicholson, currently a psychiatry professor at Dartmouth College. As a result, the diagnosis starts to speak louder than real life. Children can also pay a price when courts overstep. Research shows that forcing children in and out of different homes can leave lasting emotional scars. The logic of removing kids from parents with serious mental illness is straightforward. Studies have shown that serious mental illness correlates with higher rates of child abuse and neglect. Parents who can't take care of themselves aren't going to be in a position to take care of a child, and delusional thinking can lead to irrational, dangerous behavior, said Mary Kay O'Malley, who worked for years as a foster care caseworker and is now a professor at the University of Missouri Law School and has dealt with many cases like Mindy's. You have to put protection first. When officials fail to intervene to protect children from mentally ill parents, the results can be tragic, irrevocable, and front-page news. In one notorious 2008 case, a Long Island, New York mother drowned her 3 children after county officials failed to respond to repeated warnings from relatives that she was dangerously unstable. But O'Malley says she's seen agencies and courts unnecessarily cut off parents from their children. She says that's what happened to Mindy. 6 months after Mindy brought her daughter to the hospital, in February 2010, a parenting counselor reported that Mindy is ready to be there for Q, emotionally, mentally, and she can support Q. The parent changed in this case, said O'Malley, but the court didn't. The laws permitting termination of parental rights were mostly written in an era when serious mental illness was assumed to disqualify parents from participation in normal life, including parenting. Parents like Mindy may have been institutionalized. In many states, the mentally ill or intellectually disabled could be sterilized. The phrasing in the law has often changed. States have removed words like feeble-minded and depravity, but the same concepts echo. Indeed, a 2012 Presidential Commission report found that parents with psychiatric disabilities experience the most significant discrimination when they attempt to exercise their fundamental right to create and maintain families. We all know that many of the families whose children come into state custody are experiencing some effects from mental disorders. This presentation will give you information that can help you better help them succeed in treatment for these disorders. This is going to be basic information about the spectrum and types of mental disorders in adults, which should improve your ability to recognize and respond to disorders like these in the parents and caregivers of the children you serve. In this module, we will discuss prevalence of mental disorders. We will review facts and myths of mental health disorders, types of mental disorders, signs and symptoms of mental disorders, types of treatment and the recovery model, and other factors relevant to treatment. You will watch a YouTube video called The 10 Principles of Recovery and read an article on the NPR website entitled, "For Centuries, a Small Town Has Embraced Strangers with Mental Illness." The web addresses for the video and article are on your worksheet. You should have been provided with 2 handouts for this module. You will complete a worksheet and evaluation for this module and submit it to the training department when you are done. For the purposes of this training, we are going to use the term mental disorders to refer to what some people might call mental illness or mental health issues. This is because the term mental disorders includes the spectrums of mental illness defined by the diagnostic criteria from the American Psychological Association. Before we identify mental disorders, let's look at information from a study on psychological distress and data on mental health for the U.S. and Indiana. Be alert for answers to completing the first portion of your worksheet in this section. According to the 2004 National Survey on Drug Use and Health, an estimated 21.4 million adults age 18 or older suffer from serious psychological distress. In 2006, 10.5 million adults aged 18 or older reported an unmet need for treatment or counseling for mental health problems in the past year. This included 4.8 million adults who did not receive mental health treatment and 5.6 million adults who did receive some type of treatment or counseling. That is, about 20% of the 23.8 million adults who received treatment for a mental health problem in the past 12 months reported an unmet need. Unmet need among adults who receive treatment may reflect a delay in treatment or a perception of insufficient treatment. A 2016 Ball State University study reviewed several databases and determined that about 250,000 Indiana residents suffer from severe mental illness. 6.63% of the U.S. population reported having an episode of major depression last year. Indiana exceeded that number at 7.74%. This figure shows the lifetime history of depression for Indiana versus the U.S. The study also measured how many mentally unhealthy days people had in Indiana, on average, compared to surrounding states and the national average. Indiana topped the U.S., Illinois, Ohio, and Kentucky, and tied with Michigan with an average of 4 mentally unhealthy days each month on average. The Ball State University study also found there is only one mental health provider for every 750 Hoosiers. The best counties in Indiana have one mental health provider for at or less than 500 people. The worst counties have one provider for at or more than 5,000 people. Among all the mental health providers in the nation, less than 5% of all mental health professionals practice and provide services in Indiana. Less than 500 psychiatrists have an Indiana license and have an active Indiana practice location. Many Hoosiers seek treatment for depression from primary care physicians. However, more than 75% of primary care physicians in Indiana practice in urban locations, leaving a gap of care for rural residents. More than 80% of mental health professionals in Indiana are white. Public mental health systems in Indiana serve less than 25% of all the individuals living with a severe mental illness. Indiana is one of the least spending states for public mental health services and overall public health. In 2009, the National Alliance on Mental Illness rated Indiana's mental health care system for adults with severe mental illness as a D. Indiana scored a D in all 4 categories. This is the same overall grade Indiana received in their 2006 rating. The NAMI 2009 Indiana scorecard has been provided to you in a handout. According to the National Alliance on Mental Illness, Indiana is innovative with our state plan to cover the uninsured, but also provide coverage for inpatient and outpatient mental health and substance abuse treatment that is equal to coverage to other health concerns. We know that there is a correlation between mental health issues and income, so NAMI also looked at the steps being done to ensure there is housing for those with mental health issues. Indiana was on the list of innovative states in this area, having developed ambitious and long-range strategic housing plans with specific timelines to guide their housing activities. Indiana has dedicated specific housing resources, either capital funds or permanent rental assistance, to achieve the goals adopted in the plan. Indiana is a leader in training correctional staff about mental illnesses and crisis intervention. Stressors may come in many different forms, including personal and family relationships, economics, job or career, health, and other key life domains. Stressful life events can also impact the mental health of parents. As you assess a family situation initially and throughout your ongoing services, it is important to remember these principles. At any time, you are only seeing a moment or a snapshot in the lives of persons that are generally quite complex. Even in ongoing cases, there is always more taking place than you or other professionals on the case can know or note in your reports. Therefore, it's a good idea to try to find out what events or circumstances in that parent's past or present life might be influencing them today and what strategies have been successful for them. The incidence of mental disorders in both adults and children is higher among those living in poverty, and adults with mental disorders often slide into poverty because of employment challenges. What does this mean? We don't know that one thing causes the other, but we do know that we need to be on the lookout for mental disorders when we are working with families that are poor. All adults experience stress in their lives, but every individual has different skills to handle it. Some do well most of the time, but occasionally have more than they feel they're able to handle. Others chronically respond ineffectively to stress, and others never have difficulty dealing with stress. Stress can contribute to the emergence of a mental disorder and can trigger recurring symptoms for a person with a known disorder. This is one reason we work to increase the protective factor of parental resilience with our adult clients. Finally, try to be aware of the possibility of co-occurring disorders, especially mental and substance use disorders, in the same person when that person's life seems to have high level of stress. This will be discussed further in Module 3. Recognizing and addressing some of the stressors in the lives of caregivers, or helping them to address such stressors, is likely to enable them to more successfully and safely care for their children, regardless of the presence of a mental disorder. The information on this slide is specific to Indiana. Feeling some stress during pregnancy or while parenting is normal, but high levels of stress that continue for a long time can negatively affect a child. Children in families with high levels of stress are twice as likely as their peers to be disengaged in school and 4 times as likely to have behavioral or emotional problems. Some family stressors include having difficulty paying bills or buying food, being unable to access health care, and having a family member with a physical, learning, or mental health condition. 11.9% of Hoosier parents report usually or always feeling stress from parenting, and parents from higher income families are less likely to usually or always feel stressed than those living in poverty. Single mothers report significantly higher levels of stress than all other mothers in long-term relationships, either cohabitating or married. Parental discord can be as disruptive to childhood well-being as parental divorce. Children living in high conflict, two-parent families have more social, emotional, and behavioral problems than children living in single-parent families with minimal conflict. 23.9% of Hoosier children have lived with a parent or guardian who got divorced or separated after they were born. 50.7% of Indiana high school students live in a family that argues repetitively. More than a third live in a family that has serious arguments, and another 38.3% live in a family that insults each other. Violence is much more common among unmarried parents than married parents. 9% of unmarried mothers report being hit, slapped, or seriously hurt by the father of their children, as compared to only 3% of married mothers. Because of the way data is collected by child welfare systems, it is difficult to know how many families are reported to Child Protective Services and become involved with child welfare system because of mental disorders. Although there is not much research that documents the prevalence of mental disorders among parents whose children are involved in the child welfare system, most frontline child welfare professionals know anecdotally that there are significant numbers of parents with such disorders. We do have some information from the 2016 Kids Count Data Book about mental health with parents in Indiana. We know the prevalence of mental health problems is high among unmarried parents. Research estimates that about 15% of unmarried mothers and 10% of unmarried fathers suffer from clinical depression. Many children in Indiana live in households where an adult has a serious substance use or mental health problem that affects their everyday lives. In fact, more than 1 in 10 Hoosier children ages 0 to 17 have lived with someone who was mentally ill or suicidal. 4.3% of Indiana adults have serious thoughts of suicide each year, and 5.3% have serious mental illness. This figure shows the higher percentage of females reporting a lifetime history of depression in the past year in Indiana. Maternal depression affects the social, emotional, and physical health of children. Results suggest that many children live with mothers who report depressive symptoms, and few of their mothers receive treatment for their symptoms. Mothers with reported depressive symptoms are faced with numerous challenges, including low income, food insecurity, and weak social support networks. Young children with mothers reporting depressive symptoms consume more unhealthy foods and beverages and fewer healthy foods and beverages than children with mothers who do not report depressive symptoms, even after accounting for low income status. Mental disorders take many forms, and the same disorder can express itself differently in different individuals. Mental disorders are not something people have or don't have. Mental health is a continuum, with mental disorders on one end. It's better if we think of mental health disorders as spectrums or ranges, some more debilitating than others, and at sometimes more debilitating than at other times. Myths about mental disorders have been around a long time. You can work to get rid of these myths by understanding the facts about the treatment of mental disorders. Let's test your knowledge. True or false? Some mental disorders are contagious. The answer is false. A person cannot catch mental disorders from another person, but there are some disorders, such as schizophrenia or depression, in which a predisposition appears to be inherited from one or both parents. Trauma can trigger the development of a mental illness. True or false? The answer is true. Certain life events, such as abuse or neglect, can trigger the appearance and development of a mental disorder in their children. Most of the time, parents with or without mental illness do not cause mental illness in their children, although growing up with a parent with mental illness can be challenging. If abuse or neglect is added into the child's experience, the child can be at greater risk of developing their own mental disorders. But many mental disorders expressed by children occur in families with skilled, caring parents, so a causal link should never be automatically assumed. Mental disorders are the result of the environment. True or false? The answer is false. In the past 15 years, the field of brain science has learned that almost all mental disorders have a significant biological basis, with marked differences in how the brain and the entire central nervous system function. In particular, specific neurotransmitters, which are the chemicals that carry messages from one brain or nerve cell to another, get out of balance and cause changes in thought, mood, and/or emotion. Most persons with a mental disorder respond positively to appropriate treatments. True or false? The answer is true. Most persons with a mental disorder respond positively to appropriate treatments, such as education, medication, self-help, therapies, and other interventions. Mental health problems negatively affect all areas of a person's life. True or false? The answer is false. While symptoms of mental health disorders may not be adaptive in some situations, they can actually be very helpful in other situations. People in jobs that require very high energy functioning on an erratic basis, for example, may find that while symptoms of mania are problematic in their personal lives, they may be professionally helpful. Mentally ill people are more violent than the general population. True or false? The answer is false. Many people in our society hold fears about the potential for violence from persons with mental disorders. When you watch the news and witness visible, violent acts, you might later learn that the perpetrator of those acts had a mental disorder. In the entertainment industry, various products rely for their effect on the idea that people are dangerous because they have a mental health disorder. However, and this is interesting, statistics show that persons with chronic or episodic mental illnesses commit violent acts at a slightly lower rate than persons in the general public. Violent acts are possible, but most persons with mental disorders do not present a greater than normal risk of violence. This said, child welfare professionals should always take safety into consideration, just as when visiting any family home. There is stigma to mental illness. True or false? The answer is true. Stigma exists, and it can hurt persons with mental disorders, and that those persons have the right to escape and recover from those negative effects. Persons with mental disorders have value, want friends who see them in positive ways, and want to contribute meaningfully to the community they live in. People with mental disorders are much more complex than their label or diagnosis. That the mental disorder is only one part of what makes each individual unique. Each person has strengths and can make contributions to the greater community. Beliefs based on stigma can be wrong, and individuals with mental disorders can and do live meaningful, important lives. Each mental illness has a specific treatment. True or false? The answer is false. No practice or approach works for everyone. Treatment or service approaches have to be uniquely planned and implemented for each individual and be responsive to their unique needs and their strengths. Even evidence-based approaches and protocols work differently with persons with different diagnoses, different circumstances, and in different groups. How many classified mental illnesses are there? 95, 128, 163, or over 200? The answer is over 200. There are more than 200 classified forms of mental illness. Some of the more common disorders are depression, bipolar disorder, dementia, schizophrenia, and anxiety disorders. Symptoms may include changes in mood, personality, personal habits, and/or social withdrawal. The symptoms for any given mental disorder look different for different people. True or false? The answer is true. Each mental disorder is different, and each person with a mental disorder expresses their own individuality in the way the disorder is experienced and expressed. Another important concept to understand is that mental disorders exist on a continuum. Not all disorders with the same name are equally serious, and an individual's mental disorder will vary in seriousness over time and circumstances. Mentally ill people lack social support. True or false? The answer is true. Many people experiencing mental disorders, but not all, find themselves isolated from traditional sources of support, such as their family, often because of behavior associated with their disorder. These disorders can be hard on close relationships. They can also impact the ability to make good decisions. Some turn to sources of support, like gangs, that may put them in danger or may damage even further their primary relationships. And in some cases, people with a mental disorder may truly not realize that their behaviors are isolating them and putting themselves and their children at risk. A mental disorder may change in levels of severity for an individual. True or false? The answer is true. Any disorder may be serious or less serious at any given time, and within one individual the seriousness can and will change over time. We're going to talk now about some specific signs and symptoms of possible mental disorders in adults, hoping to help you better recognize these disorders and understand the possibilities for treatment and recovery. We'll also talk about how these signs may differ from those you see in children and adolescents. There is one caveat. By presenting this information, we do not expect to prepare you, as a child welfare professional, to diagnose mental disorders. Rather, we hope to help you recognize when a referral for further assessment by a qualified professional is appropriate. Likewise, if a parent is diagnosed in the assessment, this information will help you better understand some of the dynamics of the disorder. More common adult mental disorders may include any of the following and can be categorized broadly as affective disorders, psychotic disorders, personality disorders, and obsessive disorders. Affective disorders are disorders that affect a person's mood. Here are some of the most common affective disorders. Anxiety disorder. This is when a person experiences an anxiety so powerful that functioning may become difficult. It can be accompanied by powerful physical symptoms like shaking or the heart racing. The person may or may not identify a cause for the anxiety, but others are not likely to see the identified cause as real or powerful. Sleeping, eating, work, and relationships may all be impacted by the anxiety, which may be constant or episodic. Manic episodes occur when a person is unusually excited, happy, or active and are often accompanied by long sleepless periods, often followed by a crash that can be physical or emotional or both. Manic episodes may be, but are not always, episodic and can follow solar, body, or other rhythms. The person with mania will often have a sense of increased power or creativity or intelligence during an episode, and they often have a feeling of invulnerability. A depressive disorder is a serious manifestation of depressed mood, sometimes combined with elation, both beyond the normal ups and downs of life. Some of these disorders are cyclical, bouncing back and forth between depression and mania. Others alternate between seemingly normalcy and depressive symptoms, following inner physical rhythms. It is important to distinguish between feeling sad, or down, or blue, due to life events, and clinical depression, which lasts longer and can include thoughts of death, or slowing of activities, speech, reaction time, etc. When a person has a panic disorder, fears, real or imagined, or more general stressors lead to an intense fight or flight reaction in the body, a reaction that is very real and tends to reinforce or heighten fears already in place. The fear or experience of such a physical reaction may cause a person to alter their behaviors to avoid the situations or circumstances that bring about the panic response. Fears that keep a person from living a full, involved life are called phobias. These fears can be small and limit very little in that person's life, or they may be multiple or large and severely limit life activities. Phobias may occur in response to traumatic life events, such as confronting a large snake, or for unexplainable reasons. Their impact on the person's behavior is just as real in either case. Life disruptions caused by a single traumatic experience, such as war or natural catastrophe, or a pattern of traumatic or fearful experiences, such as a child growing up in constant fear of abuse, a victim of domestic violence. Many different symptoms may reflect PTSD, including any combination of sleep disruptions, night terrors, recurring nightmares, eating disruptions, paranoia, lethargy, disrupted relationships, phobias, and others. Following are other types of mental disorders. Eating disorders include holding a self-perception that leads to distortions in body image and consequential eating behaviors. These behaviors may include needing to eat but then purging so that weight won't be gained, avoiding eating for fear of gaining weight, fits of heavy or binge eating, or all of the above. This person may not understand why they behave in these ways and hide the behaviors from others. Obsessive-compulsive disorders are intense and often debilitating focus on certain thoughts, images, sounds, or behaviors, and/or continuing behaviors that have no inherent meaning, but are repeated nonetheless. A person with this disorder may be unable to maintain relationships or perform necessary functions as a consequence of the focus on certain thoughts or specific behaviors. An individual may be able to manage the disorder within their own environment, such as at their home or office, but show functional impairment in other environments, especially in unfamiliar or stressful environments. Personality disorders. A range of difficulties manifesting in many different ways that place a person at odds with life around them. Withdrawal from contact with others may result, and so may illegal behaviors that bring self-harm or aggression that threatens harm to others. Many persons with personality disorders are unable to recognize the differences or challenges presented by their disorder. Personality disorders are recognizable when a pattern of interaction or relationship occurs in a person's life over and over again, regardless of the individuals involved. Delusional disorders. An experience of perceptions that others do not share. Such delusions seem very real to the person experiencing them, but often put their behavior at odds with others around them who are not experiencing them. Not all delusions are psychotic, but in the most extreme form, persons may experience hallucinations, such as seeing people not there, hearing voices no one else hears, being convinced they're out to get me, using aluminum foil to shield the brain from intruding thoughts, etc. Such experiences may be assumed to be serious, possible indicators of psychosis. Psychoses, serious disruptions in thought and/or mood, such as schizophrenia. Such disruptions may be obvious, especially to persons close to an individual with the disorder, but they also may not be so obvious. Generally, disruptions involve perceptions, thoughts, and/or moods that are out of line with the person's experience as observed by anyone else. This may include hearing voices, seeing visions unseen by others, or focusing on thoughts that are held exclusively by that person and not supported by reasonable evidence. The disorder, when active, makes it hard for the affected individual to see the consequences of the disorder. Sexual and gender identity disorders. Internal mental and/or emotional confusion about one's identity or role, in conflict with societal expectations or roles, which may lead to behaviors that lie outside normal expectations or boundaries. A person may feel that they have ambiguous sexual organs or experience attractions that are outside traditional gender identities in our culture. For some, this is a serious and debilitating disorder. A person who is gay, lesbian, bisexual, or transgender does not necessarily have a disorder. They must be experiencing a compromise in their social, occupational, or other important areas of functioning for this diagnosis. Having described all of these disorders, I want to emphasize again two important aspects of mental disorders. First, virtually all of these disorders have a significant biological basis and do not always reflect the person's choices, nor do they make them a bad person. Second, all mental disorders are treatable, making proper assessment and treating planning essential to recovery. I'd also like to mention that some children and adolescents experiencing these disorders as well, but disorders under the same name, like depression, tend to look different in children or adolescents. This is one reason why mental health professionals are often trained either for work with adults or for work with children and adolescents, although a few professionals have experience across both populations. It is important to try to match professionals with the appropriate expertise to the person with needs. The following are signs that someone may want to speak to a medical or mental health professional. There are many different mental disorders that can affect adults and their ability to be good parents to their children. The most common element in the many different mental disorders is that thought processes, or mood, or emotion are different in persons with mental disorders than in many other people. The development of children may or may not be delayed or damaged as the result of being parented by adults with mental disorders. When such a disorder is suspected or identified in the parent, child welfare workers must pay attention to the developmental milestones of children in the family and take action to address possible delays or difficulties. Generally, persons with an emergency mental disorder become less effective in living their lives, often described as less functional, but that lack of effectiveness can be different for different people and might show up as employment problems, health concerns, failed or fractured relationships, or poor emotional regulation, such as outbursts, unpredictable reactions, explosive anger, or even a totally flat affect in situations meriting a reaction. Your goals are to be committed to helping identify mental disorders and assure successful treatment, supporting a parent to successfully and safely care for their children. If a worker can provide direct assistance, or if positive outcomes can be achieved through an appropriate referral to another helper, then prevention of a removal and/or family reunification can be supported. The important thing to remember when planning an intervention is that the cause of a disorder, which could be biological inheritance, early trauma, or just learned behaviors, is less relevant than the current impact of the disorder on their ability to live their lives or to function. If minor children depend on adults with such a disorder, those children may or may not experience inconsistency and difficulty. We've talked about the kinds of mental disorders that parents you encounter might experience, but what about helping them? It is important that you have some understanding of the kind of treatments that might be offered in response to the identification of mental disorders. In this presentation, I'm going to talk about model treatment, management of mental disorders, and treatment services, collectively known as interventions and supports. Many different community-based mental health interventions, services, and supports are currently being used, and these can be used in any combination. When the diagnosis is correct, an appropriate medication applied in appropriate dosages can counter the negative impact of many mental disorders. Medications should be monitored regularly for effect, and some medications require regular physical or blood tests to prevent or monitor potentially harmful side effects. It is often effective to educate individuals about the nature and impact of mental illnesses they may have, giving them a chance to understand and take control of their own mental and physical health using strategies that have been shown to be effective. Some persons are able to talk with others about their illnesses or symptoms in ways that help them gain insight and additional abilities to manage their own disorders. Therapies may be provided to individuals, to entire family groups, or to treatment groups of persons with similarities. Still, counseling and the various therapies are not necessarily effective for everyone with a mental health disorder. Some people with complex or very serious mental disorders respond well when a paraprofessional or professional staff person agrees to work with them to help manage the delivery of care through the community system. This role may be very simple or very involved. Many persons with a mental illness have someone in their life that cares about them and looks after them to varying degrees. Those caregivers may become exhausted or overwhelmed by the care responsibilities and may need periodic relief. Respite services provide relief like this on a scheduled and/or emergency basis. These teams provide multidisciplinary expertise immediately accessible to those who are most seriously impacted by significant mental disorders, constantly assessing needs and managing system responses that assist an individual to remain outside institutional placements. Many people with mental disorders manage their difficulties well when they have daily access to a structured program with opportunities to develop socialization and other life skills and access to necessary supports. Many adults with mental disorders have someone caring for them, and day treatment programming may allow the caregiver to fulfill job responsibilities or get respite from the challenges presented by day-to-day care. Many consumer-led services and supports have emerged in the past decade and are effective for many people with mental disorders, helping them manage their own disorder and remain functional in their community. A wide array of self-help options exists across communities, with peer-to-peer relationships at the heart of successful support. The most expensive and generally least effective long-term model of treatment for adults with mental illness is psychiatric hospitalization. This service is extremely important when it is needed briefly for stabilization, accurate diagnosis, or medication adjustment, but hospitalization is needed rarely and should be used as infrequently and as briefly as possible, unless it is the only environment in which the person is not a threat to themselves or others. The availability of hospital beds varies widely across states and communities. Persons within the mental disorder treatment field hold a wide range of beliefs about people in general, about mental disorders, and about the best type of care for these disorders when they are identified. Still, in broad categories, there are a few major approaches to these issues, including the following. Behavioral model. This model theorizes that all behaviors are learned. Treatment focuses on decreasing problematic or painful behaviors and replacing them with more effective or positive behaviors. Conditioning and behavioral management skills are taught and supported. The cognitive behavioral therapies reflect this model. The biological model is based on the idea that emotional and behavioral aberrations reflect physical problems or anomalies. Mental disorders may result from regulatory and/or management difficulties that stem from differences in the way a person's brain or body functions. Treatment focuses on finding the physical cause of the problems and treating it medically. Treatments include interventions like therapy, medication, repair or adjustment of physical functioning, rehabilitation, etc. In this model, all behaviors are the consequences of interactions between the individual and his or her environment. The individual cannot be neatly separated from the environment. Treatment is designed to learn more about these interactions and make adjustments in the person, the environment, or both. The interactive model acknowledges every other model in this list. It says that behavioral problems are the result of complex interactions between biology, environment, learned behaviors, and other factors. Treatment may include any number of approaches or combinations. The psychoanalytic model says that behavioral disturbances result from the person's mental life and past experience. Treatment focuses on helping the person understand his or her thinking about the past, or gaining insight about the impact of past experiences through talking about their experience. These are overly simplistic descriptions of major mental health models. Most treatment professionals combine elements of many of these models depending on the individual or their care and their symptoms. When talking with treatment professionals, it is often helpful for the child welfare professional to ask them to explain the model or treatment approach they follow so that you can better understand how to effectively coordinate your child welfare casework with the treatment interventions. The adult mental health care system continues to develop new approaches that reflect what is called a recovery model of care. Recovery is based on the belief that a person does not have to remain seriously and negatively impacted by their mental disorder, and with appropriate treatment, education, and supports, most people can quote-unquote recover from mental disorders and lead normal, productive, hopeful lives. Similar to adaptations people make to physically challenging conditions, people live with mental disorders learn to adapt their lifestyles in such a way that they can maintain the state of recovery, sometimes for years. This approach challenges stigma about persons with mental disorders and their chances for life success. This model also challenges some of the traditional mental health treatment approaches and the roles played by treatment professionals. Pause this video now and view the YouTube video listed on your worksheet describing the recovery model. Sometimes people with mental disorders resist or reject the types of care that could help them function more effectively in society. This resistance doesn't make them bad, but it can reflect a predictable part of some mental disorders. Such persons may need constant reinforcement and support to accept and receive appropriate care. It is also important to remember that treatment cannot be forced on anybody. Also, certain medications used to treat thought or mood disorders can affect persons of different races somewhat differently, and this can explain some resistance to treatment. It is also important to use mental health professionals who are aware of such differences and are willing to find another way to treat the person without judging them. There are a number of things you need to consider when you are working with parents involved with the child welfare system. Let's first consider parents who may have been impacted by trauma earlier in their lives. One thing to keep in mind is that adults who experience physical or emotional abuse or fear of abuse through childhood are at increased risk for experiencing mental disorders. But remember, while such a disorder does not define who they are, it may substantially influence who they are. When a person grows up with traumatic events, for example, as a victim of child abuse, their life in general and their parenting more specifically are likely to be affected in some way. A parent who has been abused by their own parents sometimes grows up to treat their own children the same way they were treated. In fact, child abuse is often cyclical, repeating itself through family generations. On the other hand, although people raised with abuse may continue that abuse in their own parenting, growing up with abuse does not automatically mean that a person will abuse their children. We are now going to consider the link between mental disorders, suicide, and other violent behavior. As I pointed out earlier, people with mental disorders are statistically less likely than their peers without mental disorders to commit violent acts. You might not realize this because when people with mental disorders commit violent acts, they can be more extreme or bizarre, which draws media and public attention to them. For example, people experiencing delusions, especially delusions of paranoia or persecution, for example, a person diagnosed with paranoid schizophrenia, may act unpredictably, even if they are in treatment. And people who attempt or commit suicide are more likely to be suffering from depression, whether diagnosed or not, than someone who is not depressed. Many completed suicides are by people who have not been previously identified as depressed, and many are impulsive acts by people in crisis who have access to the means to commit suicide. On the other hand, people suffering from depression are not necessarily suicidal. Finally, there is some evidence that adolescents who begin taking certain antidepressant medications may have a higher risk of aggressive or suicidal actions when they first start taking these medications, although this can be managed through careful medical monitoring of medication and treatment. Generally, mental disorders are not commonly linked to aggressive behaviors. Suicide is common, but not always linked to depression, and the presence of substance use may exacerbate the effects of any mental disorder. Relationships are important to everybody, those with and those without mental disorders. We all need to have relationships with people who care about and accept us, and we need opportunities to care about and interact with other people as well. As a child welfare worker, you may be able to support and/or facilitate such relationships for people whose disorder makes it hard for them to find such relationships for themselves. This would be increasing the protective factor of social connections. How are your clients' relationships affected by a mental disorder? People adjust to each other more or less in all relationships, affected by the interaction of the strengths and needs of each. Seek information about the person's relationships at home, at work, and in other community environments. Try to hear how those relationships are impacting the client. Are they satisfying? Are they supportive? Are they stressful? Ask them about relationships with children. It is important to listen carefully, trying to understand the consistency of parenting messages in that particular family. If the person shows any awareness of a possible disorder, ask them to whom they might turn for help. As gently and respectfully as possible, encourage them to talk with someone, whether it is you, if you're willing, a friend, another professional, an advocate, or a family member. Reaching out for help increases the strength and likelihood of improvement, whereas withdrawal or isolation generally tend to exacerbate mental health needs and disorders. There is importance of community recognition for each individual, no matter their challenges, and acceptance that they can contribute to the community when given a chance. Each person can have meaningful relationships with other community members, and everyone does not have to be the same to have or enjoy the benefits of community relationships. Mental disorders or mental illnesses are a reality for many people. The disorder is not something to be ignored or denied, nor should the person be judged negatively because they suffer from such a disorder. The disorder is part of who they are, but they have many other parts. But with any of these disorders, setbacks or relapses may take place, but even individuals who experience such setbacks can still remain on their own unique path to recovery. Individuals may seek support from wherever it is available. Ideally, parents with mental disorders will receive services and supports from persons qualified to help them in meaningful ways. You should be familiar with appropriate resources in the community and help parents access those resources. The ultimate child protection goal is to keep children safely growing up in their own families. Parents whose parenting abilities are negatively affected by their mental disorders may succeed with proper identification, treatment, and management of their disorder. You may be the ideal helper to encourage and support such care. In this model, we discussed prevalence of mental disorders. We reviewed facts and myths of mental health disorders, types of mental disorders, signs and symptoms of mental disorders, types of treatment and the recovery model, and other factors relevant to treatment. You watched a YouTube video, The 10 Principles of Recovery, and read an article on the NPR website entitled, For Centuries, a Small Town Has Embraced Strangers with Mental Illness. After you complete your worksheet and evaluation for this module, submit it to the training department.